Multiple sclerosis, MS, is an inflammatory disease affecting the central nervous system. It damages myelin, the protective layer surrounding nerves. Relapsing remitting MS, RRMS, is the most common type. Others are also listed. MS patients are diagnosed through medical history and neurological exams that include MRI and lumbar punctures for cerebrospinal fluid analysis. MS is at least 2 times more common in women than in men, but studies have suggested that the female-to-male ratio may be as high as 4:1. This may be due to sex-related differences in immune responsiveness, steroid effects, and hormone variability. Europe contains more than half of the global population of individuals diagnosed with MS. Canada has one of the highest rates, and India one of the lowest rates of disease prevalence. Typical symptoms include discrete episodes of numbness, tingling, weakness, vision loss, gait impairment, imbalance and bladder dysfunction, and fatigue and heat sensitivity in between attacks. Symptoms vary greatly from one patient to another. The onset of MS is associated with UV exposure, poor diet, smoking, exposure to viral and bacterial agents, and vitamin deficiency. Activation of CD4 T cells, important immune response regulators, migrate into the central nervous system by passing the blood-brain barrier. Additional T cells and macrophages are then recruited, causing inflammatory lesions, resulting in myelin loss and axonal damage, leading to neurological dysfunction. Studies have shown an association between the human leukocyte antigen, HLA genes, and the risk of developing MS. It was found that a specific allele, HLA-DRB1 15.01, is shown to increase the progression of MS symptoms. MS develops slowly and differently in everyone. A diagnosis of MS must include evidence of damage in at least 2 areas of the CNS, evidence that damage occurred at different points in time, and after all other possible diagnoses are ruled out. Medical imaging using MRI can reveal brain lesions, and lumbar punctures assess nerve damage. There is no single test that can diagnose MS, and many conditions mimic it. 1 in 5 MS patients are misdiagnosed with other similar conditions. Fibromyalgia and MS both involve the nervous system and share some similar chronic symptoms, such as muscle weakness and pain. However, they differ by pain from fibromyalgia that lasts a long time and is described as dull, achy, and persistent. Confirming the diagnosis for MS is a challenging process and can take a long time. An example of this is Jackie Pylon, a woman from Saskatoon who was misdiagnosed with MS for 20 years, but is actually living with acute disseminated encephalomyelitis. Though there is no cure for MS, treatments focus on recovery from attacks, slowing disease progression, and managing MS symptoms. Medical therapy can slow down its progression in early stages. Corticosteroids are prescribed to reduce nerve inflammation. Treatment options include injectable medications, oral and infusion treatments. An important addition to treatment is physical therapy that includes stretching and strengthening exercises and the use of devices that perform daily tasks easier. Exercise can improve endurance, strength, and also provide better control of bowel and bladder function. It is important for patients to exercise in a healthy manner and avoid overworking the body. Always check with your physician or physical therapist before beginning a new exercise plan. As of now, the goal of current treatments is to block the cells that cause inflammation and damage to the nervous system. This includes preventing the immune cells from crossing through the blood-brain barrier and into the CNS. Research for future treatments focuses on preventing further axonal damage and remyelination, which may return function for MS patients. For the latest research, support groups in your area, to donate, and for more information, go to mssociety.ca.